Welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we bring this podcast to you every Wednesday as a veterinarian, as a technician, as a dentistry team to help you be even better at veterinary dentistry in your practice. We're sponsored and partnered today with the Veterinary Dental Practitioner Program. If you're interested in being among the best anywhere in general practice as a team in veterinary dentistry, I invite you to request an invitation. Just go to ivdi.org/INV, like invitation, first three letters INV. So IVDI, International Veterinary Dentistry Institute, ivdi.org/INV, and we'll get you the information that you need. What classes are available to learn root canals? Short answer to that, there are none. The AVDC prohibits veterinary dentists from teaching root canal therapy to general practitioners. The learning curve is way, way too high, and I used to tell people 10 years ago, 12 years ago, whatever it may be, 15 years ago, that I've been doing root canals after becoming a specialist for 10 years, and I think I'm just now getting good. And so that kind of puts perspective into how difficult these things are from a decision-making standpoint. We don't teach these. They used to at the dental forum. They don't anymore, because they realize that's not the thing to do. You don't see enough, you don't have enough practice. And enough practice is probably 5,000 to 10,000 hours of practice to get really good at these, where you can do them and do them quickly and efficiently. So not something that you'll do in practice, not something that you're willing, unless you're specializing, to put the time into to make it happen so that you're good and you're providing a good value to the patient. So, Anisha, how do you convince or explain to clients the need or importance of extracting devitalized teeth, or ones that are just partially extracted and the owner perceives the dog not to be in pain and they are acting normally? So that's a great question, and that comes up a lot in our courses. So client education, this is one really good example that takes all those things that you talked about and puts it into one good example. You've got a tooth that may be slightly discolored. There's no crown impingement. There's no changes in that tooth that are visible other than the color change. Or you have a tooth that has a lucency radiographically, but looks perfectly normal with no color change. So those two situations may be difficult to explain to the client without having good images. So if you've got the Veterinary Dental Image Library, which a lot of you have, I think when you registered for this workshop, you had an opportunity to get that. I think it's $17 or something like that to get it. It's got a lot of images that you can use for client education. And Sonali, if you're in the chat, put that in there, the image library link, and they can do that, or search for Veterinary Dentistry Image Library in my name. You'll be able to find that. You can get that as a PDF. You can put that on your computer and use that for all client education. You can show them a lucency on a tooth and let them know that that tooth was what happens when these teeth that are discolored are allowed to go for any length of time. If you don't have that patient where you've got the radiograph of the tooth that's not discolored already, so that would be for a discolored tooth in the exam room, show them what that progresses to in most instances, even if there's no pulp exposure. That discolored tooth is discolored because the pulp is dead or dying. When that pulp dies, it releases toxins and metabolites that destroy the bone around the tooth apex that result in that lucency. So it doesn't have to have infection associated with it. It's just those toxic metabolites of pulp necrosis that cause the inflammatory condition that results in the periapical loss of the bone. If that's the case, then you're gonna not have a radiograph if you're talking about this in an exam room. That's where images that have been taken previously come in handy. If you've got the radiograph and the client has declined extraction or root canal because they don't believe it's a problem, then you show it to them at discharge and let them know this is a hole in the bone that's created because the pulp's dead. That hole is not going to stay stable. It's going to get worse. It may cause a fistula eventually, although it takes years for that to develop. And in the meantime, that patient is suffering silently because that is uncomfortable, if not painful, with that bone destruction and inflammation that's going on. So hopefully that answers your question. Certainly covers that whole scope, I hope. And so let's move on to the next question. And then Christiane, what can I advise my clients who are interested in referral for a potential root canal as what to expect as far as monitoring goes for the lifetime of the animal? That's another real practical question from a potential referral, from a general practice potential referral standpoint, which should come up a lot now that you guys are well versed in what the potential for root canals would be versus not root canals. So what do we tell the clients going to be involved with that? So number one, if you're coming to my practice, we're going to put a crown on that tooth, and then unless that patient's older and doesn't have an expectancy of 5 years to still be with us. So we're going to put a crown on that to protect that, because we know that micro leakage happens around any composite restoration and can start, and generally does in humans, around 5 years after that restoration is placed if it's not covered with a crown. And we're going to put a crown on there. So that's a 2-visit thing. If your dentist that you're referring to places crowns, which a lot of them do, some of them don't, then that is going to be a 2-visit procedure where we do the root canal, we do the preparation for the crown with burrs, and then we make an impression, send that off to the lab, and then in 2 weeks we get the patient back. There's going to be that recheck. And then when we get a patient back, or when you get a patient back for a routine cleaning in a year, 18 months, 6 months, whatever it may be, depending on the patient and their periodontal status, we recheck the radiograph. And in our case, we've got pretty much, I would say, 98% of the ones we follow up are going to work. There are very few that we've ever had to extract or do surgical root canals on over the years. Depends on what you look at. 92%, 93% is what the literature suggests. There's a real good possibility there's not going to be any problems or follow-up going forward, except for routine radiographs. That should answer your question. If there is a failure, which happens by some measure, then that's either redo the root canal, a surgical root canal, which is a whole nother ballgame and conversation, or an extraction on your end, or the referring vet or the referring dentist, or the dentist that you referred to would be doing that. And if that's coming in to most practices, it's down the road a bit, where it's had time to develop over time, and there may be root dissolution in conjunction with that, and so extraction is usually what ends up happening with those. All right. Thanks, Anisha Kumar, for that. Beth Shawn had some questions the last time, and she's got a question this time. If tertiary dentin's present at the site of a fractured crown, no lucency present on radiographs, do you need to extract? So the question is, it all depends on the radiographs. If that has been sealed and it actually sealed off with tertiary dentin, but the changes had already happened deeper and the bacteria had gotten in there, or that tooth was compromised from a pulp standpoint and the trauma itself killed the tooth, then there's no reason to extract, and there's probably no reason to really follow that up, because the tertiary dentin has already come in there and healed that. And if there's no radiographic changes after that month or multiple months that it's taken for that to happen, then there's a chance that they won't. Most of the tertiary dentin we find is generalized with wear that's happened in younger patients over time, that the owners have stopped the wear behavior. Just as an aside, if there's no changes that would suggest that's a non-vital tooth, you do not need to extract. You don't want to extract. Let's go down to Megan's question. What is your recommendation for a puppy who comes in with a fractured deciduous tooth? And the answer to that is extraction, and extraction that day, if possible, because that pulp's exposed. That pulp is huge, and it's going to get infected if it's not already. The puppy may or may not show that it's uncomfortable because they're puppies. They're not 90 to nothing all the time. Nothing seems to bother them for the most part. And any things that they do, rubbing their face on the ground or rubbing that side of the face, maybe just be perceived as puppy behavior. They're active anyway. And so it's not really picked up if they're uncomfortable. And those things can abscess, and often do, and they go undetected, and the dog suffers until the body takes care of that and eventually resolves it after weeks. Always extract those, and always get pre-op radiographs to make sure you're getting all the tooth root, because some of those might be partially resorbed. And a lot of them will have apical to the mucogingival junction, or at the mucogingival junction, they'll have a fistula. You can actually see that fistula, but not always. That's when it breaks through the bone and affects the tissue. So yes, you want to extract those. All right. So let's go to cases that have cysts. So we're going to talk about that now. And very common to see these, although you may not have seen them, probably because you're not looking for them and taking radiographs on every indication that there are, or every indication that there is, to take radiographs for finding these. So let me start off by saying, if you have a brachycephalic breed with a missing O5 or first premolar, upper or lower, and specifically lower would be the more common situation. Upper is super less common, but lower O5s in a brachycephalic breed, first premolar in the mandible, if that's not there, there's a really good possibility that there is a cyst forming, or that will form. If this is a patient less than 18 months old, 2 years, you're taking radiographs, if there's no cyst that's forming yet, probably not going to be if you don't see it radiographically, but I would still follow it up in another year to make sure. But if it's an older patient, you don't see anything, if it's unerupted, it's not going to happen. But if it's less than that age, if you're there anyway, get it out because there's a good chance that's going to progress. The crown is under the tooth where the tooth's supposed to be, which is in the oral cavity. It's in the bone. There's an epithelial root sheath around that tooth that produces fluid. That fluid expands, and by 3, 4, 5, 6 years of age, you get tremendous bone destruction from the cyst. You want to make sure that if you get these early, when the patient's less than 18 months old, go ahead and extract them. Get them out of there before they have a chance to produce the changes that we see. And we see those changes that are really bad. I hope you enjoyed that episode. If you'd like more information about the Veterinary Dental Practitioners Program, please submit to request an invitation at ivdi.org/INV.